Hi, my name is Bruce Strober, and today we'll be talking about the use of methotrexate for the treatment of psoriasis. I am the professor and chair of dermatology at the University of Connecticut Health Center, and I primarily specialize in the treatment of moderate to severe psoriasis patients. So the objectives of today are to discuss the role of methotrexate when treating psoriasis, its biologic effects, its efficacy when used orally, and its efficacy and tolerability when used as a subcutaneous injection. And then we'll wrap things up. And keep in mind, a lot of what I'll say is based on personal experience too, trying to add or shed light on the objective data. First, let's sort of go through the treatment guidelines that are out there, and quite variable around the world and from indication to indication. We'll really try to focus mostly on psoriasis therapy. Now, the American Academy of Dermatology has a laundry list of recommendations listed on this particular slide, and I think it's important to go through them to some extent. First and foremost, the indication for the use of methotrexate in psoriasis is, in my opinion, a little bit too high a bar. It says severe recalcitrant disabling psoriasis, not adequately responsive to other forms of therapy. In reality, methotrexate should be used when topical therapies or phototherapy are not indicated or practical or effective, and in people with moderate to severe psoriasis. For the most part, we have to use methotrexate first as a systemic therapy because not only does it work at a very low cost, most payers would prefer that approach unless there are contraindications for its use in any given patient. Some of those contraindications are absolute, such as pregnancy and nursing, people who have alcoholism, people with severe alcoholic liver disease, people with immunodeficiencies, or bone marrow issues that cause leukopenia, thrombocytopenia, anemia, and of course someone who's got a hypersensitivity response to methotrexate. More importantly, there are relative contraindications that allow you some leeway to use the medicine in certain circumstances, but nevertheless should give you pause or at least prompt you to use more careful monitoring with these kinds of patients. For example, people with renal insufficiency, which allows the collection, the buildup of methotrexate in a person's body and therefore may cause more anemia or bone marrow suppression. People with abnormalities in liver function, of course, which may be because of hepatitis or some degree of alcohol intake, or people who take other medications that affect the liver. And then there are people who are at risk for infection or display active infection, people who are immunosuppressed. Of course, women who are trying to conceive should avoid methotrexate, but it's now a recommendation that men within 3 months of trying to conceive should as well avoid taking methotrexate. That's somewhat of a controversial recommendation. Not everyone agrees with it, but it is currently in the label. People with a recent vaccination, with a live vaccine, should take a break or not start methotrexate. In my opinion, that's probably about a week after the live vaccine is given. You should wait before you take methotrexate again. And then there's these, in my opinion, soft contraindications such as obesity and diabetes. I have very often used methotrexate in obese, overweight patients and people with controlled diabetes, even though that may present a greater risk to liver toxicity. Again, you could use methotrexate in patients with obesity or people who have diabetes, but you perhaps want to monitor their livers more closely over time. Of course, an unreliable patient would be someone you'd likely avoid this drug with. The European guidelines are pretty generous. They allow for initial and long-term use of methotrexate in an evidence-based manner, and as well allow both oral and subcutaneous use of the medicines. In fact, you will find, in general, European practitioners are very friendly with the subcutaneous dosing approach and rightly find it a better approach for people who need methotrexate. In this slide, we see recommendations from the Spanish, and I only bring this up because while they arrive at the correct dosing, between 10 and 20 milligrams per week of methotrexate as a starting dose, and perhaps going up to 25 milligrams a week in some patients, what they also talk about here is subcutaneous injection of methotrexate being an option if people are not doing well on oral methotrexate or have poor tolerability to oral methotrexate. That's how I would often use subcutaneous methotrexate. And finally, rightly so, people should be allowed about 12 to 16 weeks on methotrexate in order to determine their clinical response to that drug. Now, this slide really enumerates the recommendations of the AAD with regard to methotrexate. And generally speaking, while I had something to do with these guidelines, I no longer fully agree with them. I'll just say shortly, I don't do liver biopsies anymore for any of my patients on methotrexate. We would be the only specialty, in fact, that uses this drug that actually sometimes considers the liver biopsy. You will not find the liver biopsy done in rheumatology, for example, even though they treat psoriatic patients who have psoriatic arthritis in addition to people with rheumatoid arthritis. And also, the belief I have is that liver biopsies are not good because they're a bad test. Liver biopsies rely on a sampling accuracy, which we know can't be there. It's a small core of the liver that's taken, and therefore you may miss overall disease, or you may capture disease in a very small area where a liver may be in majority not affected. And finally, liver biopsies have risk unto themselves. The procedure itself carries risk. So I tend to avoid a risky procedure that provides me unreliable information. And for that reason, I basically rely on liver function tests, transaminases, knowing full well they're not always reliable. What we have to get comfortable with methotrexate use is we currently don't have a very good test for toxicity in psoriasis patients, even though new technologies are being developed. And the best we can do is try to avoid high-risk patients and monitor with laboratory evaluations at an appropriate interval. Let's talk about the biologic effects of methotrexate. We all were taught that methotrexate works by interrupting the cell cycle and therefore blocking proliferation of relevant cells. For example, in the skin, the keratinocyte, when using low-dose methotrexate, is interrupted in its proliferative abilities. In truth, methotrexate works because it's an anti-inflammatory medication that through a variety of means blocks chemotaxis of relevant immune effector cells, for example, neutrophils, Langerhans cells, and other antigen-presenting cells, and probably through similar mechanisms blocks the production and secretion of relevant cytokines such as IL-17, IL-23, and tumor necrosis factor. And finally, blocks NF-kappa B. It should be made clear that, by and large, the effects of methotrexate probably have something to do with increasing endogenous levels of adenosine, a molecule found in all of us, yet when upregulated in its production, actually is a very effective anti-inflammatory molecule. Methotrexate, therefore, in sum, probably has most of its effects on inflammation by increasing levels of adenosine. You know, not surprisingly, as this slide shows, when you give an effective therapy for psoriasis and you look under the microscope at their skin, you see normalization of the features of psoriasis into the features of normal skin. So in this regard, unsurprisingly, people have improvement in features such as parakeratosis or loss of the granular layer, removal of pustules and Monroe microabscesses, and commensurately we see improvements in the PASI score. So similarly, this slide shows that if you give a large number of psoriasis patients methotrexate and you normalize them clinically, you also will normalize them histologically. Let's discuss discuss the studied efficacy of oral methotrexate for the treatment of psoriasis. In fact, we know the efficacy of this drug through a variety of well-controlled trials. The sum total of most of the reliable studies for oral methotrexate in the treatment of psoriasis really arrive at a treatment effect of about 40% between the people on methotrexate and the people receiving a placebo. So if you had to hang your hat on the PASI 75 achievement rate for oral methotrexate, it's 40% of patients. There's a pretty well-established concept that people who do well on methotrexate at, for example, 12 to 16 weeks of therapy may continue to improve past 24 and 36 weeks of therapy. So the best way to summarize this slide, which I think is clinically valid, people doing well on methotrexate can tend to improve over time, and therefore you really don't want to close the book on the final efficacy for these particular patients until at least 6 months has elapsed. You know, it's not surprising that the more of the oral methotrexate you give to a population of patients, the better off they'll do. These two lines show that 25 milligrams per week of the oral medicine arrives at a lower PASI score earlier than 10 milligrams a week of methotrexate. Now, I would state that past 17.5 milligrams of oral methotrexate, you get to a point of diminishing returns because bioavailability goes dramatically downward with the oral methotrexate. Still, there is benefit to more oral methotrexate when trying to treat patients with psoriasis up until a certain point, and we'll get to that later in this talk. This slide basically shows if patients have better pharmacokinetic retention of methotrexate during dosing, they tend to show lower PASI scores over time. So the area under the curve of methotrexate at week 1, as shown on the x-axis, when you have higher numbers on the x-axis area under the curve, you get lower PASI scores. This just speaks to the bioavailability of this drug being incredibly important. Later we'll learn that bioavailability can be unpredictable with the oral methotrexate, and it's perhaps the glutamic acid or polyglutamation of methotrexate that matters more with regard to efficacy. Well, this is a complex slide, basically derived from the CHAMPION study done by AbbVie, where they compared methotrexate to adalimumab, and they just analyzed the methotrexate arm of this study, which was about 100 patients. And just to summarize, and this is a very important point when using methotrexate, most of the responders are going to be realized, or I should say unveiled, by 15 milligrams per week. And when I say responders, I'm talking about PASI 50 response, a low bar. But if you give 15 milligrams per week orally of methotrexate, by and large, you will uncover the people who are going to respond to this drug, such that increasing its dose to a higher amount, 17.5, 20, 22.5 milligrams per week, will gather you very few additional responders. Really, it's diminishing returns as you increase the methotrexate dose orally. And again, that points probably to a bioavailability issue. 15 milligrams is the optimum dose to start with, and it's probably the best dose to reveal efficacy for any given patient. Let's talk about a very important variant of psoriasis, palmoplantar psoriasis. We all know that's harder to treat than your run-of-the-mill plaque psoriasis. This was an important study where they actually compared in 111 patients methotrexate, dosed appropriately, against acitretin, a retinoid which we've always heard is really good for palmoplantar disease. Well, this study, by measuring the 75% reduction in what they called a palmoplantar PASI, shows that methotrexate does better than acitretin. It's something I've always thought to be true. I give methotrexate ahead of acitretin when it comes to treating palmoplantar disease. In fact, I think acitretin is a very hard drug because of its tolerability issues and the inability to give it to women of childbearing potential. So Methotrexate is a better drug than acitretin for palmar-plantar disease, probably achieving this PP PASI in about 40% of patients, whereas acitretin is about 30% of patients. It's a difference that's noteworthy and something I've seen clinically. A separate active line of investigation has been the effect of medicines for psoriasis on cardiovascular comorbidity. Methotrexate had some of the earliest data showing it may actually help prevent vascular disease in people with not only rheumatoid arthritis but also psoriasis. I actually think this Pradanovich paper out of the University of Miami, published in 2006, was a landmark paper. Through a study of VA patients, it was shown that methotrexate significantly reduced the risk of cardiovascular disease with confidence intervals lower than 1. Patients actually with psoriasis did better than people with rheumatoid arthritis when it came to the lowering of cardiovascular events on methotrexate. So you can think of methotrexate as cardioprotective, and there are ongoing studies investigating this issue further. Just in case you thought that was the only study that showed this, there are many other studies that point to a protective, a cardio or cardiovascular protective effect of methotrexate. Again, the overall effect appears to be about a 25 to 30% reduction in cardiovascular risk when patients receive methotrexate for inflammatory disease states. To be clear, these analyses have also been done using TNF inhibitors, and it appears TNF inhibitors are even better than methotrexate in reducing cardiovascular risk. It may be not a mechanism of action issue, but perhaps just the ability of a TNF inhibitor to clear the skin better than methotrexate. All of the currently approved TNF inhibitors used for psoriasis are better in efficacy than methotrexate, and that may account for the better cardiovascular risk reduction. In fact, recent data suggests that any drug or modality, such as phototherapy, that reduces the burden of psoriasis on the skin may be cardioprotective. Well, it's clear that some people on oral methotrexate don't stay on the drug very long, and there are a variety of reasons why that may be. This slide depicts some of the major ones, for example, lack of efficacy or adverse events or tolerability. I would say those are two of the major reasons why patients don't stay on oral methotrexate. It doesn't work probably very well for over half the patients who get it. We know there are other options now for patients, for example, biologic therapies that work better than methotrexate, and therefore that may induce physicians and their patients to switch from a lower efficacy medicine to a better efficacy medicine. But as well, tolerability plays a role. A lot of patients just don't feel good on methotrexate, and again, when there are other options that may be better tolerated, you're going to see an incentive to come off medicine. This analysis basically shows that gastrointestinal intolerability and lack of clinical response drive patients to discontinue oral methotrexate. This slide adds one more issue that leads to discontinuation of oral methotrexate, primarily personal reasons as opposed to intolerance or ineffectiveness. I don't know what those personal reasons might be, but they may be related to I don't want to be on this medicine that I need to have blood work for every 3 to 6 months, or I'm worried about my liver, or I want to drink more, or I want to conceive a baby. There's many different personal reasons and lifestyle reasons, to be more specific, that lead to discontinuation. And no one's going to kid ourselves with regard to methotrexate can be a lifestyle-altering medication, and therefore patients are sometimes looking to get off of it. This slide doesn't add that much more except to say the survival for methotrexate over time is not good over the course of 5 years. This is just 85 patients. Again, side effects and ineffectiveness were invoked as the primary reasons for discontinuation. This is very controversial. A study was done, and this is just one study, but it's often referred to, of 125 patients who were treated with methotrexate for psoriasis and basically treated for a long time. The median cumulative dose was over 2,000 milligrams over approximately 4 years median time. And a lot of liver biopsies were done on these 125 patients, actually 278, which is a lot. That's 278 more than I would have done. That said, they analyzed the level of liver pathology, and most patients over that time were grade 1 or grade 2, 85%. And then there was about 18% who had mild, moderate fibrosis or cirrhosis. It's important to note that most people did well, but some people had a worsening of their liver histology over that time period. It's hard to ever know what's normal in this group of patients because these studies are never done with a control group who's not on methotrexate. And of course, that would be impossible to do because you'd have to literally biopsy people's livers who are not in need of a liver biopsy. It's a risky procedure. But I just don't know whether the psoriasis liver, which we know is less healthy than other livers, other disease state livers, is going to undergo these kinds of transitions over this period of time in this many people with or without methotrexate. It is well known that people with psoriasis are much more likely to be overweight or obese and actually much more likely to have non-alcoholic fatty liver disease or worse, non-alcoholic steatohepatitis. Features of the psoriasis liver that are independent of methotrexate use. So what are they measuring in this study? Is it methotrexate-induced damage to the liver, or is it psoriasis-induced damage to the liver? This study does not answer that question. So this is a study on patients drinking alcohol while taking methotrexate for rheumatoid arthritis. It's an analysis of patients over about 30 years in a very well-established database. And what it established was drinking about 14 units of alcohol per week or more and caused significant rises in the transaminases when compared to less than 14 units of alcohol per week. It should be noted that 14 units is approximately 8 ounces. I think a unit of alcohol in this study is equal to about 7 drinks per week, just the best way to convert it. So our understanding of units should be converted into drinks. 14 units is 7 drinks, 2 units is 1 drink. And so it kind of goes with what I've been saying all along, that a patient could have a drink, whether it's a beer or a mixed drink or a glass of wine per day, and they're going to be okay. And again, this is RA data, not psoriasis data, so the generalizability is a little unclear. Let's talk about subcutaneous methotrexate for psoriasis therapy, a modality I use quite often in my practice. Why use subcutaneous methotrexate? Because it improves bioavailability. As this chart shows, in the green we have oral methotrexate, and as you move up in dose along the x-axis, you see a plateauing of bioavailability, area under the curve of methotrexate, really beginning about 15 to 20 milligrams per week. With the purple line, the subcutaneous patients, you see more of a linear increase in bioavailability over the dosing range, so that in the end, when you're giving methotrexate sub-Q, you know you're getting a linear response, and the more you give, the better delivery of the drug is being done. In this slide, we have a complex depiction of variability of the pharmacokinetics of methotrexate. So let me take you through it. The oral version of methotrexate given to 57 patients is depicted in the green histograms. And you can see as you move across the x-axis in methotrexate dose, 7.5, 15, 22.5, and 30, the green histograms are up, down, variable. We don't get a consistent area under the curve And therefore, the upshot is oral methotrexate does not give predictable bioavailability at each dose. Whereas you can see the area under the curve coefficient of variation for the purple histogram, sub-Q, is pretty much constant. You really don't see differences in bioavailability with subcutaneous dosing, no matter which dose you're giving of the drug. A lesser well-recognized important aspect of the biology of methotrexate is what it actually does once it's inside of cells. Methotrexate is really a prodrug. In other words, it comes in as methotrexate, but it must be converted to what's called a polyglutamate version of itself by the addition of new glutamyl groups. So when patients are effectively responding to methotrexate, in fact, what they're having done is an accumulation of polyglutamate methotrexate inside of the cells. So as this slide builds, you will see that methotrexate that's polyglutamated inhibits what's called ICAR transformylase. And when you inhibit ICAR transformylase, you show an accumulation of ICAR, which leads to an accumulation and release of adenosine. And remember, I said adenosine is that potent anti-inflammatory molecule we all have. Methotrexate, in essence, when it's more polyglutamated, causes more release of adenosine, which then binds to the adenosine receptor. That is the anti-inflammatory biologic correlate of methotrexate therapy. So, as I said earlier, long-chain polyglutamated methotrexate is associated with clinical response. Only the adjustments, after adjustment, the association between methotrexate polyglutamated moieties actually causes meaningful change in PASI. So what you really need is methotrexate with a lot of glutamyl residues put on the end of it in order to get better efficacy. This slide basically compares oral to subcutaneous methotrexate. Again, oral in the green histograms and purple histograms for subcutaneous. And you can see methotrexate, when it is given sub-Q, gets many more polygglutamated versions of methotrexate. As we moved from left to right along the x-axis, we see the purple histograms are taller than the green histograms. And this is somewhat of a landmark study published in The Lancet this year, 2017, where in Europe, a large number of patients were randomized to receive either a placebo for 16 weeks or injectable subcutaneous methotrexate at a starting dose that's quite robust, 17.5 milligrams per week, with the option to escalate to 22.5 milligrams over time if PASI 50 was not achieved. Now, it should be noted that these were all methotrexate naive patients. They were all adults, and they had psoriasis for at least 6 years and had moderate to severe psoriasis. And finally, at the primary endpoint, the placebo group, 16 weeks primary endpoint, the placebo group is crossed over to actually get the injectable methotrexate. So this slide depicts the 52-week results of the study. The purple line are the patients who got methotrexate sub-Q from the get-go, and the green are those patients who got placebo for the first 16 weeks and then converted over to getting methotrexate at week 16. And I would ask you to focus on the PASI 75 improvement rate in the upper right, basically showing 41% of the sub-Q methotrexate receiving patients are at PASI 75 at week 16, and after the placebo period ends, that number goes up to about 50%. And you can also see the placebo group that's crossed over shows demonstrable improvement, as they should. I think that the data from this study in terms of efficacy are very clear. Somewhere between 40 and 50% of patients achieve PASI 75 on sub-Q methotrexate. It tends to get better, the response over time. Maybe that's real. Maybe that's because we lost a placebo group after the 16th week. but it appears the efficacy is a little bit better here than we saw with the oral studies that were done previously. The adverse event data are pretty clear. I mean, most patients do well with AEs when compared to placebo group from week 0 to 16. Noteworthy are some increased rates of hepatic enzyme increases, transaminitis, 2- and 3-fold the upper limit of normal. There's about 3 or 4 times more of those patients in methotrexate treatment than placebo, though the rates are still pretty low. It's about 9 to 11% of patients in the methotrexate group, where it's 3% in the placebo group. So clearly, not surprisingly, there's a few more patients who get liver enzyme elevations receiving methotrexate. You also see a little more nausea and vomiting in patients getting methotrexate when compared to placebo. Not surprising. What you're seeing, though, mostly is a great tolerability. There are no MACE events, there's no depression, no infections to speak of, and really no more infection in methotrexate receiving patients than placebo receiving patients over 16 weeks. And this should give you, comfort that what we know about methotrexate is relatively correct, and the things we monitor for and tell patients about are accurate. This study also shows, which is different than the previous, shows that sub-Q methotrexate in a retrospective analysis, a registry, is better associated with higher persistence. In other words, people stay on medicine. 80% of patients are still on medicine after about 28 weeks of therapy. And that probably speaks to 2 issues. One, sub-Q methotrexate works better than oral methotrexate, and secondly, is better tolerated. Kind of a complex study here where patients were switched from oral to sub-Q methotrexate, which is often how I do it. And when you switch people from oral to sub-Q, why are you switching them? Well, you tell the patient, one, sub-Q often works better. I can give you more of this drug, sub-Q, and you're getting more of it. There's no plateau of its bioavailability, in other words. Secondly, it's clear that people getting sub-Q methotrexate tolerate the drug better. So a good way to put this, based on these data, about 40% of patients who are switched for tolerability reasons from oral to sub-Q do better on the tolerability aspect of the drug. And as well, about 50% of patients, with regard to efficacy after the switch from oral to sub-Q, do better. So tell patients, there's about a 1 in 2 chance that switching you from oral to sub-Q will either give you better tolerability or better efficacy. Again, we're comparing oral to sub-Q in this chart. We have green histograms for the oral. We have purple for the sub-Q. And across the board, what you're looking at, gastrointestinal tolerability, whether it's nausea in its frequency or nausea in its intensity or vomiting frequency or just GI discomfort. In every metric, we're seeing patients tend to do better with the sub-Q administration when compared to the oral administration. So in summary, we have national international guidelines that recommend the use of methotrexate for the treatment of moderate to severe psoriasis. Often it's a first-line systemic because of low cost and high benefit. It's a very high benefit to risk ratio, in my opinion, when you use methotrexate, and it's very cost-effective. And that's why it's used around the world and will continue to be used around the world for the rest of our careers. Methotrexate works because it's anti-inflammatory when given at low dose. It upregulates an endogenous anti-inflammatory molecule in adenosine, and that probably has very positive effects on immune effector cells and cytokines, which ultimately results in normalization of the skin in patients who respond. Oral methotrexate works, and sub-Q methotrexate works better, has more predictable pharmacokinetics when you give more of the drug, and importantly, shows better tolerability. Actually, not mentioned here, it's often the case that sub-Q methotrexate is more cost-effective. Now, finally, I didn't mention this, but I think to have a safe experience with methotrexate goes to proper patient selection, obviously selecting patients who would present a lower risk for side effects and adverse events, but as well good monitoring. And I would suggest that in addition to baseline liver function tests, complete blood count, quantiferon gold or PPD for latent TB, hepatitis B and hepatitis C serologies, you then go forward by carefully measuring the liver function tests and the bone marrow monthly for at least the first 3 months, and then quarterly thereafter if patients are having no problems. I do not do a test dose for methotrexate. A lot of my colleagues agree. I start methotrexate at approximately 15 milligrams, whether it's given oral or sub-Q, and I bring them back in about a month to repeat the blood work and just make sure they're tolerating medicine well. Everyone on methotrexate, in my opinion, should be getting folic acid supplementation, be it folic acid 1 milligram per day, every day, even on the dose of administration, or folinic acid at 5 milligrams, taken at 3 doses per week, 12, 24, and 36 hours after the dose of methotrexate that week. Either way, you will protect the liver better and increase tolerability of the drug. I hope everyone has learned something from this talk. I hope everyone feels comfortable with methotrexate. It is a medicine we need to know how to use either as monotherapy or in combination with biologic therapy to help the biologic therapy work better, prevent immunogenicity, and therefore work longer. And with that, I conclude. Thank you very much.